Thank you all for joining us and welcome to our webinar on psychiatric emergencies. So before we proceed, I would like to say a few introductory remarks about Yetenaweg. So Yetenaweg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. Currently has more than 70 active volunteer members spanning across 5 different countries. So our projects and engagements are divided into 4 aspects. The first is health promotion, which is usually done through discussion and articles regarding the health of the general public and also health policy and its implementation. Our other major engagement area is community engagement. So this is usually through blood drives, inclusivity trainings, equity projects, and fundraising campaigns. So our other project is mentorship and skill sharing. So we provide direct mentorship, soft skill training, career and professional development via webinars. And our last is our medical education wing, which has the CME, or the continued medical education, and the research and quality improvement projects. So Yetenaweg is more than a digital platform. It also provides the opportunity for its volunteers to meet at specific intervals and contribute to the society directly in person. So as you can see from this image, these are images of various members in various activities, including inclusivity training and blood donation campaigns. So this is also another slide showing our volunteers participating in other volunteering programs such as donation and inclusivity trainings. So Yetenaweg also collaborates with ROHA and IMSA for its health article writing competition. So the third round has already started. The fourth round, has already started. So ROHA Medical Campus will award travel grants for 2 health article writing competition winners. And Yetenaweg will award pulse oximeters for up to 20 winners and litmus stethoscope for the top 3 winners. And the top 5 winners will also get internship opportunities at ROHA Health and other partner institutions. So on the left side is an image showing the 2021 article writing competition winner accepting her prize. And on the right hand is also a picture showing the prizes that were awarded to the 2022 winners. So this is also another image showing the 2023 article writing winners that got the opportunity to travel abroad and participate at the University of Global Health Equity. So Yetenaweg also collaborates with ROHA for its research fellowship. So Addis Ababa University Medical Faculties Division was started on March 14. It includes 3 departments: oncology, radiology, and internal medicine. So research grants were awarded for the top 5 winners, and mentorship opportunities were given for the next step. And this is also done with St. Paul Hospital Medical College, but instead of residents, medical students, mainly interns, were the ones that participated in this fellowship. So research grant has been awarded for 4 winners, and the winners have already been announced. So this is a slide showing the research and QI fellowship winners from Tukur Ambassa. So as you can see, there are 2 residents from internal medicine, another from oncology, and another from radiology. So these are also the winners from St. Paul Hospital. Okay, so coming to our CME, our CMEs are freely accessible, and Yetenaweg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, and the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. So we've had 10 CMEs held so far for the year 2024. Our average webinar attendees range from 150 to 200 healthcare professionals. So we invite renowned local and international speakers. And in 2024 alone, we've planned more than 30 webinars focusing on emergency, surgical, and medical case, ENT, pediatrics, OBGYN, and others. So you can access our previous CME sessions by going to our YouTube channel, where they will be uploaded once the session is over and the editing is done. So in order to get updates about our upcoming CMEs, you can join our Telegram channel for healthcare professionals. The link will be shortly pasted in the chat box, or you can follow our social media posts via Twitter, Facebook, LinkedIn, Instagram. So in order to get the best experience in the webinar, you can send your questions to the Q&A or to the chat box by the end, and your questions will be addressed by the guest speaker accordingly. And to get your CU certificates, you must be able to fulfill the following set of criteria. So you have to attend the whole sessions virtually, because the minutes attended will be checked by Zoom's attendee report. You have to fill in the Google form for personal details and attendance. So the credentials you provide should be accurate. There should be no typo error in order to avoid delay in certification. And you should be able to score 50% or more on the post-webinar quiz. So you'll get your results right away, but the certificates will take 1 up to 2 weeks to be delivered to your email inbox. So we ask that you wait patiently. And whenever making queries, we'd also like to remind you to at least wait for this time frame before forwarding your queries. So this is all about Yetenaweg. So our guest speaker today is Dr. Eshetu Tumiso. So Dr. Eshetu is a highly accomplished psychiatrist with extensive experience in both academic and clinical settings. So he graduated as a medical doctor in 2015 from RC University and later specialized in general psychiatry in 2021 from Tukur Ambassa Specialized Hospital. So Dr. Eshetu has made significant contributions to the field of psychiatry in Ethiopia. He established the Department of Psychiatry at Walqite University and served as the department head, leading both the academic and clinical wings. Additionally, Dr. Eshetu has compiled psychiatric treatment guidelines for common psychiatric problems, which has been instrumental in improving patient care. So he also established a psychiatric inpatient service at Butajra Regional Hospital and served as a visiting psychiatrist at the hospital. So currently, Dr. Eshetu holds the position of Assistant Professor of Psychiatry at St. Paul's Hospital Medical College. He also serves as the postgraduate coordinator at the where he continues to make valuable contributions to the field. So alongside his academic responsibilities, Dr. Eshetu also actively practices psychotherapy at the outpatient service level. So having said that, I would like to welcome our guest speaker. So Dr. Eshetu, please proceed.
Today we'll have discussion on the psychiatric emergencies. Basically, we'll focus on the adult part. And these are the outlines, introduction to this concept, the psychiatric emergency. We'll try to see the treatment setting, the epidemiology, and how to evaluate the patient, which is actually the part of treatment in psychiatry. Evaluation is basically it's a therapeutic process. You will try to treat patients. It's your first encounter, it's your first words. And we will see some of the common conditions which lead to psychiatric emergency, like delirium, psychosis, and suicidal behaviors, and so violence, and the treatment principles. When we see the psychiatric emergencies, they are defined as any unusual behavior or mood or perceptual or thought problems that, if not rapidly attended, might result in harm to the patient or to others. That means that any disturbance which is, leading to the immediate therapeutic intervention is necessary to do this. The current time, as the violence and psychiatric emergencies are increasing progressively due to different issues. For example, medical illnesses leading to the psychiatric behavioral changes, alcoholism, drug use, and suicidal behaviors, and also aging, which are associated predominantly dementia and delirium. These factors, they are leading to the increment of the violence and also the psychiatric emergency. When we see the historical background, initially the psychiatric emergency concept was initiated by, or it was formed by the Legal Act in USA in 1963, which was establishing psychiatric emergency as the one of the department, or it was a standard or a law which is enforcing hospitals or any mental care should have this emergency service. And before that, there are many people, actually, they were using in 1904, especially in the Russia, they were using this, treating the soldiers at the front line or at the battlefield by encouraging their healthy component and this sense of patriotism, encouraging the soldiers, and they return to the battlefield after stabilizing and managing their crisis. In Italians, they were also using these PTSD patients. Almost 60% of the soldiers will remit to the intervention, I mean, to the battlefield or front line after the intervention of crisis management. In Americans, in 1943, after patient developed the psychiatric emergencies, whether it's PTSD, acute brief psychosis, or anxiety, or malingering issue, any behavioral changes leading to psychiatric emergency, only 80% of them return to the battlefield initially. But after a year, they have started crisis-oriented therapy. That means the crisis management currently actually in multiple settings, we use it by using different techniques, supportive environment, ventilating, relaxation techniques. Then 95% of the soldiers who have developed these psychiatric emergency symptoms, they were returning to the battlefield. You can see the effects in the economy and also for that soldiers, generally the disease burden will be very low if we manage psychiatric emergencies. These are the common causes, for example, patients with present with psychiatric emergencies, with chronic psychiatric illnesses after they have developed relapse, for example, schizophrenia, bipolar illness, depression, psychosis. Patients who present with medical illness, due to stroke or seizure or other infections like cerebral malaria or meningitis, they will present psychiatric emergencies. People will present psychiatric emergency after adverse drug reactions, intoxication due to alcohol or other substances, drug-drug interactions, or after they have experienced violence on themselves, after they have become traumatized or victims, as we see in the current situation in Ethiopia. When we see the places where psychiatry emergency happens, people usually think like it will happen only in the hospital setting, but that's not the right. It will happen in anywhere. Psychiatric emergency could happen at home, at the streets, at OPD, at the psychiatry unit, wards, emergency, at the medical surgical unit, at the operation rooms, or the emergency department, at the churches, wherever people are engaging with others, psychiatric emergency will happen. Therefore, when we see the treatment setting, most of the psychiatric emergencies are not initially visited or treated by psychiatrists. Non-psychiatrists are, encountering with them. Dominantly general practitioners in our setting, residents from different departments, and other professional nurses who are working at the ICU. Therefore, non-psychiatrists mostly evaluate the patient. Therefore, you have to know some of these principles engage, because you are going to encounter it almost in your daily practices. The first principle when we set the treatment setting is safety and security. The safety issue is dominantly you have to focus on the safety of the patient and also the safety of the staff, the treating physicians, nurses, and also even the institution, the materials, the environment. You have to have adequate number of staffs, at least 5 members of the staff who will help you on the management of psychiatry. Emergency team which are trained how to manage these issues, and you have to have immediate access to the medical emergency room, the psychiatric emergency, wherever you manage it. You have to have this access to the emergency or medical management, because 1/3 of the medical patients will present psychiatric manifestations. That means almost 33% of the patients, 1 out of 3 patients from the medical problem will present with these behavioral issues, disturbance in thinking, disturbance in their moods, or disturbance in the behavioral perception changes would happen. You have to have also full spectrum of psychopharmacological options, IV drugs like diazepam, haloperidol, and PO, lorazepam medications, and also other emergency essential drugs like 40% IV line, saline, and other oxygen and the like. We need to intervene if something medical emergency happens. And there should be a clear code of conduct that guides all the staff members and also the patients. You know, in our setting, people tend to abuse patients with behavioral disturbances, whether they are psychotic or whether they are delirious. It's very common to abuse the patients. They are the victims of the violence or abuse by the health care. Therefore, we have to have a clear code of conduct, which is, prioritizing the right of the patients and maintaining the safety of the staff who are managing it. You have to have seclusion room and also restraint room for people who are trained on this issue. And you have to separate these agitated patients from non-agitated. Whenever you are trying to manage emergency on psychiatric setting, it's good to separate them from non-agitated patients. It will disturb them and also it will increase the risk of violence in another group of patients. You have to be very aware of the patient's world, their expectation, or sometimes their expectation could be just a fantasy, or that could be their delusion. Sometimes it would be a real expectation. You have to focus on what they are saying and what they are expecting you and from the setting. And the last thing when you organize the treatment setting is you have to focus on the surrounding or the environment that you are going to treat the patient. Objectives, therefore. For example, people might throw IV stands on the physician, or they might use weapons, they might hold it, or they might use it from the emergency sets or scissors, anything that the patient could use to harm themselves or to harm the staff. You have to focus on this environment. Nothing should be there which is potentially used as the weapon by the psychotic patient or disturbed patient. And there should be an equal access for the patient and also for the physicians in the room. When we see the epidemiology of the psychiatric emergencies, they are visited by both men and women equally, and more single patients will visit psychiatric emergency than the married people. And when we see out of the patients who are visiting psychiatric emergency, 20% of them are suicidal patients, 10% of them are violent, and most the common disorders from the psychiatry side are mood disorders, both depression and mania, and schizophrenia, and alcohol. Alcohol is highly associated with psychiatric emergency, whether it is during the intoxication or whether it's a withdrawal or alcohol-induced psychiatric problems. And out of the patients, 40% of the patients who need this immediate psychiatric emergency will be hospitalized, and the rest of them could be managed, and you can send them back to home or link them to the OPD for the regular outpatient management. And most of the visits for the emergency are at the night hours. As we can expect, people will visit the hospitals with this behavioral disturbance due to different reasons. When we see the alcohol-related issues or substance-related issues, dominantly they are engaging on this time, and also the family members might observe them, and these are the common times. And as I have said, 1/3 of the medical conditions will present with psychiatric manifestations. When we see the evaluation, as I was saying on the introduction, it will start with the first words, how you say, how you greet the patient, how you interact with that patient. Therefore, the primary goal on this process is timely assessment of the problem and connecting with the patient, having a good therapeutic alliance. You know, we don't start the intervention after the assessment. We start the intervention with the assessment. While we are assessing, that process is very therapeutic. The words you use and how you interact, your gestures, and also your empathic approach, showing your understanding to them. Therefore, you have to make the clear connection with the patient when you are evaluating them, and then you will settle the initial diagnosis, whether which is a medical disorder or psychiatric problem, psychosis, mood issue. You will try to make the clear diagnosis. Then you will try to identify the precipitating factor. Almost always there are the precipitating factors on the immediate development of this behavioral change in most of the patients. Sometimes if it's a recurrent illness, you might not identify clear precipitant, but at least there should be some communication gaps, how people were interacting with them. Therefore, it's good to try to figure out the precipitant. Then you will try to decide whether you are going to treat the patient at that evaluation site, or you will try to decide to refer them to better setting, depending on the condition. For example, if the patient is developing behavioral disturbance or psychosis due to acute coronary syndrome or hypertensive encephalopathy, it's not good to keep the patient at the psychiatry side or at that general medical emergency side. Therefore, it's good to transfer them to the proper and appropriate setting where the interventions, immediate interventions will done, the cardiac interventions or whatever, depending on the cause of that behavioral issues. And whenever you try to evaluate the patients, if at that site, the psychiatry unit or at the medical side, it's good to keep the number of the patients to the minimum. If it's good to keep one patient at one room, if it's possible, but in our setting, that's very challenging. At least you have to minimize the number of the patients at that room. While doing this, you can take the history from the patient or from the collateral. That's very important. While you are talking with the patient, you have to do the mental states examination. You have to focus on the risks, the thinking, how people are doing this, their behavioral, general appearance issues, and also the safety. Basically, whenever they interact with you or whenever they talk, always when you assess the patient, safety is the first concern in any interaction. Then you do the physical examination and also baseline laboratory tests, for example, random blood sugar, CBC, electrolyte, thyroid function tests, and alcohol level. Sometimes, depending on the patient's urine analysis, will be very important. These are the common illnesses which are associated with psychiatric emergencies, for example, anxiety or depression. Even psychosis will happen with hypothyroidism, hyperthyroidism, DK, diabetic ketoacidosis will present with this, hypoglycemia could present with psychiatric emergency or the psychotic symptoms, UTI or pneumonia, severe pneumonia, or severe malaria, myocardial infarction, alcohol intoxication, alcohol withdrawal, COPD, or liver disease, hepatic encephalopathy, or substance withdrawal will present with this. And common psychiatric issues that are leading to the psychiatric emergencies are abuse on the child or on the adult, adjustment issues after patients experience loss of the material or internal displacement, as we see in our country, or other different transitional issues, changes happening on their life, marriage or divorce, conflict. These adjustment issues, side effect of the medication, the delirium, as we are mentioning, marital crisis, catatonia, and mania, neuroleptic malignant syndrome, severe side effects of their medication, their paranoid state, whether it is due to their personality or due to other substance or even the schizophrenia. Sometimes the victims of rape will visit the psychiatry emergency, seizure, panic attacks, and also suicide survivors will visit the emergency. When you establish this issue or when you try to manage the patients, there are constituents that we need: admitting area at that emergency, or the area that we will keep the patients, or if it's in the centers, detoxification center. You can do this in the private medical office if you have an adequate staff and adequate number of people. And you have to figure out these medical issues, commonly head traumas, acute intoxication management principles, these withdrawal states, associated with AIDS. Currently, this stroke is very common, present with this issue, or post seizure, people will present with this issue. Therefore, you have this expertise to manage this. The basic issue is, if it is ideal or if you can afford to this, triage should be done with psychiatrists, which are with more experienced people on the mental health consultation, and licensed psychiatrists or emergency psychiatrists. They can easily screen the patients whether this behavioral change is associated with the medical problem or whether it is associated with psychiatric problems. Then you can involve other people. Before you implement these issues, these are the basic questions, 5 questions that you have to answer. What to do and where to treat the patient before you decide this. The first is safety. Is it safe for the patient to be here? Is it safe to keep the patient at the medical emergency? Or is it safe to keep him at the psychiatric emergency or gynae side? Therefore, when you decide the management, it should be safe for the patient. Priority is the safety of the patient. The second thing is this problem is associated with organic problem? That means biological disease, medical problems causing the behavioral issue, as I was mentioning. Or is it a functional problem? That means psychiatric symptoms. Or is it a schizophrenia? Is it a bipolar illness? Or is it a combination of both? Many patients will have this. Most of the patients with severe mental illness, they are neglected. Therefore, they will have medical disorders. And the most common cause of death in psychiatric patients is not suicide or not directly associated with psychiatric problem. It's a medical problem, cardiovascular disease, cardiac illnesses, or stroke, cerebrovascular accidents. Therefore, patients could present with both. Bipolar disorder patients, they could have stroke, they could develop, cardiac illness or whatever. Therefore, you have to focus on that. Is this thing an organic or the functional or combination of both? Or you will try to focus. Then the third one is this patient is psychotic? Psychosis is a failure or detachment from the reality. Once someone is psychotic, therefore it needs different approach to interact with them, because there is a clear break in the reality testing. They will have their own worldlet, the perceptual disturbances, thinking disturbances, the behavioral disturbances associated with this. Therefore, is this patient psychotic or not? Then, is this patient suicidal or homicidal? Patients might kill themselves, or they might kill their family members, or they might assault the health care workers or professionals. Therefore, you have to focus on this issue. You have to rule out this risk of suicide and risk of homicide. The last one is, to what degree is this patient capable of self-care? if you are going to intervene, your management should depend on the level of the self-care. If the patient has no capacity to feed, or if the patient has no capacity to work, therefore, sometimes they might need ICU or whatever the issue, depending on this. Therefore, we have to focus on this issue. The safety of the patient, whether it's a biological illness, whether the patient is psychotic, whether they are suicidal, and degree of the self-care capacity. These are the general strategies when you are evaluating and managing the patient. The first one is self-protection, in healthcare. When you are evaluating the patients, you are violating their personal space, auscultating the chest or examining the abdomen, touching people. You are invading their personal space. Therefore, you have to know the patients, know them before you evaluate or touch them. Therefore, you have to understand them. Is this patient is psychotic, or is this patient is manic, or whatever? The second one is you have to have physical restraints at that room, trained people, and soft restraints you can use. You have to be very alert, whether there are impending signs of violence. We'll see them one by one. You can predict the risk of violence in a given patient when you are trying to evaluate them. And also the safety of the surrounding, as I was mentioning, the objects. People might use this against you or to harm themselves. And never try to evaluate acutely disturbed patients alone. Have others with you. People might develop other medical emergencies, or they might assault you. Therefore, it's good to have a team, at least a member of 5 people once working with them. And once a patient is psychotic or agitated, the only tool between us is our words. Therefore, trying to connect with them without the word, what you say, the first word, how you say it, and what you say, it matters. Therefore, that is the only thing between you and the patient. And you are trying to them, try to prevent the harm, self-injury or suicide or the risk of violence. You have to clearly inform the patient. Acting violently or trying to assault other people is not acceptable, or it's not allowed in this institution. You can post that at the visible places at the emergency, and whenever you interact with them, you should approach them with a non-threatening manner. Most of the patients could be paranoid or delusional. At that state, if you use the threatening words, they will understand or incorporate you as the part of their delusion, and they will assault you. Therefore, non-threatening issue. This is very common, actually. In most of the violences or assaults, physicians or the residents or general practitioner, they will provoke the patients in the manner how you say a word or how you talk with people. And as a population also, in our community, we are not good at how we say words. Dominantly, you can see this at the taxis or on the media. We are very, harsh when we are saying words. Therefore, we shouldn't repeat this at the psychiatric emergency. Once they are agitated, they are very hypervigilant. They will react for minor stimulus. We should take care of this. Most violence are associated with the provocations. You shouldn't provoke patients. Reassure them. You can calm down them, or you can give them a water or something like the tissue. You can tell them that this is a safe place. You are a physician. You are there to help them. This is a hospital. You can do this, and if there is a difficulty, you will use these restraints. We will discuss about this issue. Always rule out organic problems. As I was saying repetitively, 1/3 of medical patients will present with psychiatric symptoms. These are the issues that are suggestive of medical cause of mental disorders. Then you see, when you evaluate the patients, you have to suspect medical cause of that behavioral disturbance if it is an acute onset. The behavioral disturbance is happening within an hour or minutes. This is possibly due to the medical condition. Therefore, you have to suspect the medical condition. If this is the first episode of the behavioral disturbance, especially on the old age, older than 40, or in the younger age, less than 12 years. If this is happening for the first time, therefore, it's good to focus on this issue. In the geriatric age, if the patient is having the current medical illness, comorbid injuries, road traffic accident, or other chronic medical illnesses, hypertension, cardiac illness, renal issues. Therefore, if there are current medical illnesses, patient develop behavioral issue, you have to consider the medical cause of that thing first. If the patient is substance user, currently using alcohol or other dominant drugs, currently almost all the drugs are, available in informal way in Ethiopia, people use them. If the patient is experiencing non-auditory disturbances, that means visual disturbances dominantly, or olfactory hallucination without auditory hallucination, that's suggestive of the medical cause of that disorder. Dominantly psychiatric problems, auditory hallucination is the most common form of hallucination. If the patient has neurologic symptoms, for example, loss of consciousness, abnormal body movement, severe headache, the pattern of the headache, change in their vision, and when you do the classic mental status examination, or mini mental status, if there is a change in alertness, or there is a problem in orientation, memory problems, concentration, attention, if the patient has calculation problems or speech problems, movement, gait disturbances, these are highly suggestive of the neurological origin of that issue. When the patient difficulty to draw a clock or to make a pentagons or to draw a circle, if these are the issues, you have to consider medical issues. These are what I was saying. If this is, for example, fluctuating course, the state of the patient's symptoms are fluctuating in a day pattern, that you will suspect delirium in this condition. Okay. When you consider the safety issue, whenever you evaluate the patient, at least you have to stand away around 6 feet. That means a handshaking distance when you are talking. But if the patient is very paranoid, suspicious of you, or highly agitated, you have to increase that distance 2 or 3 times from the usual distance. You have to keep that distance when the patient is very agitated. And as I was saying, when you are taking history or evaluating, doing physical examination, you are doing this in their personal space. Therefore, they might be very paranoid, or they might act out this issue. How to enhance safety and security in the psychiatric emergency, whether it is happening on the psychiatry side or on the medical side. The first thing is the hospital system should screen for weapons when people, they try to enter to the hospital. At the gate, this should be very strongly tight security issue. People shouldn't possess these weapons and visit hospital. Physicians, we have no anything to protect ourselves. You are there with your gowns, or with your gloves, or with your stethoscope. Therefore, the hospital system should do this. We see these issues. Sometimes patients, will visit you at the OPD and they will have a gun with them. or people will visit the medical emergency with gun. This should be strictly controlled. This is how we enhance the safety and security. The second is the rooms where you examine should be having at least 2 doors for the patient and for yourself. It shouldn't be very, closed, or you shouldn't put yourselves at trap. Most of our OPDs or physician office, they are enclosed and you are at trap. That's very risky, actually. You should design that, or whenever you try to set this issue, you have to design in that way, hospital or the treatment setting. And the alarm systems should be there. You can use this panic button, electronic. Currently, they are available everywhere. Therefore, you have to clearly install these alarm systems with the buttons you can touch, or you can ask for help, and educate number of people. Whenever you try to manage this, at least, as I was saying, 5 people should be there with trained security people, with yourself, with the physicians. When you try to see some of the disorders that will lead to psychiatric emergency, the first one is delirium. 20% of the patients who are admitted or hospitalized to the medical setting or surgical or emergency, they are due to delirium. Therefore, delirium is a very common problem in the medical setting, which is an acute decline in both level of consciousness and the cognition. Basically, the dominant impairment is on the attention, but people could have this perceptual disturbances, psychomotor activity disturbance, or sleep cycle abnormality. It will have a diurnal variation in the case of delirium. And the problem is often healthcare workers, they don't recognize delirium. They might consider it as just the character of a patient, or they might consider it as the psychosis, or they might consider it as other psychiatric problem. It's very often missed by healthcare workers, with the general practitioners or family physicians and other professionals. It's likely to be missed. Therefore, you have to focus on, is this a delirium or not? You have to rule out that. And these organic disorders, as I was saying, they are commonly presenting with these neurological symptoms, tremor, and the change in the coordination or incontinence, whether it's urinary or fecal. When people are having this issue, you have to consider delirium. And if you detect this immediately, the cause of the delirium, then you can easily eliminate that. People will respond within a short period of time if you treat the cause of that delirium. These are the common names for delirium: intensive care unit psychosis, acute confusional states, acute brain failure, encephalitis, encephalopathy, toxic metabolic states, sundowning, cerebral insufficiency, organic brain syndrome. These are the common names which are used at different settings, but all represent delirium. How to manage delirium? The first is always delirium should be treated at the general hospital setting. It shouldn't be treated at the psychiatry unit, because it is directly associated with the cause, which is medical, for example, stroke or whatever. But some form of delirium, specifically delirium tremens, which is associated with alcohol withdrawal, or severe delirium associated with benzodiazepine withdrawal, it could be treated at the psychiatry side. But if it's very severe enough, actually what's recommended is ICU management. Delirium tremens due to the alcohol withdrawal, it should be treated at the ICU, intensive care units. Then you have to focus on to decrease these physical, sensory, or environmental sensations. You have to support the patients. Once they are delirious, it is Could be hypoactive or hyperactive, or it could be mixed. You have to calm down the environment. You have to approach them with familiar staffs or familiar friends. Or you can post the pictures or decorations at that room, or you can reorient the people on the daily basis. Just you can tell them today is a Monday, or you are at the hospital, we are with you, I am your physician or my friend, whatever, orienting them. And delirium needs medication in these three conditions. If there is a clear psychosis and if there is a clear agitation, patients need antipsychotic medication. If there is a clear sleep disturbance, insomnia, then they need sleep pills. Unless and otherwise, most of the managements are treating the underlying condition of delirium. It's not dominantly a psychiatric treatment. Basically, it's the medical issue, treating the underlying condition. The second one is psychosis. People, they are clearly withdrawn from the objective reality. They have disturbance on their faith. You have to focus on this issue, their level of intellectual functioning, their degree of regression, that means their degree of disorganization, how they are agitated, the paranoia dominantly, if they are very suspicious toward this view, or if they are experiencing commanding auditory hallucinations, the voices telling them to harm themselves or others. Whenever you are interacting with psychotic patients, the basic thing is, you have to be very clear on your communication, straightforward communication. People assume that lying a psychotic patient, telling a false story will help the patient, but it is not helpful. You have to be very clear, and you have to try to be their external ego or their external reality testing function. You have to be very reality sensitive. Therefore, clearly communicate what is happening. For example, the patient, you can tell them you are agitated, you are very talkative. At this state, you might harm yourself or you are going to harm others. Therefore, we are going to help you to calm down. We are going to give you pure medications, or we are going to give you injectable medications, or we are going to restrain you with this reasons. You are clearly at this stage. Therefore, it's good to inform people. And whenever you interact with agitated psychotic patients, your interaction should be very brief. They have no capacity to listen to long sentences or scientific jargon. Just use one word or two words at a time. Try to use restricted, short, precise words. And you shouldn't assume that this patient will trust you or they will want your help. Therefore, this is a common thing that we see. People will assume that this patient will accept. It's not to say if you tell someone about the risk, they are not going to accept that. Therefore, your role is just to inform them and you will see the response. Never assume on the interaction. Actually, never assume in any interaction, not only in the psychotic patients, but in any interaction. Assumption is very problematic thing. If you see the risk of agitation, you have to terminate the interview and try to manage that thing. Initially, tell them to, or try to de-escalate them verbally. How to de-escalate, we'll see on the coming slides. Then tell them to take pure medication to calm down themselves or to assist them. If they refuse that, tell them that you are going to inject them without their will, or you are going to restrain them to protect them and to protect the system or yourself from the imminent danger. When we see the third thing is suicide, These are the issues which are, suggestive of suicide warning signs. When any patient who is with mood disorder or any psychiatric problems or medical problem, if you see mood changes on the patients, if patients are socially withdrawn from others or social withdrawal, suicidal talks when they talk about wish to die, or always when they are wishing to end their life, or when they say all this is to end, or these hope issues, when they raise this, you have to suspect these are the warning signs. When people are very preoccupied with death, whether it's a philosophical thing or whether it's a religious teaching, when people are very preoccupied with death talks, you have to suspect suicide. And you have to also see the previous gestures or their attempts and the imminent suicide risk predictors are when people plan to harm themselves. If they have a specific plan or preparation, if they write a suicide note, goodbye things. You can see this on the social media in the current times. People might post at the Facebook, or they might text their friends or family members. And when they give away their personal possessions, their materials, when they give it to other people, when they are interested, they are not interested in these possessions, or when they arrange their final meeting with you, or when they see these final arrangements with others, these are the direct suicide predictors in the immediate suicide risk. How to assess suicide? As you know, the sad persons score. Sad persons is a mnemonic. S stands for male sex, age younger than 20 and older than 45, depression, previous suicidal attempts, alcohol use, rational thinking loss, psychosis. That means social support lacking when people are isolated, if they have an organized plan, if they have no spouse or they are living alone or single, or they are divorced, or if there is a chronic illness, chronic cancer or chronic medical illnesses, this will predict the risk of suicide, and we'll use them how to assess. But from this, if there is a depression, clear full-blown depression, which is highly associated with suicide, if there is a clear disturbance in the thinking, psychotic experiences, if the patient has organized plan and loss of hope, these are highly suggestive of suicide. Therefore, to assess the suicidal issue, people assume that asking suicide or about the suicide or talking about the suicide directly will increase the risk of suicide or committing, but that's not evidence-based. Rather, asking about the suicide will decrease the risk. Therefore, directly ask people like this, how do you feel about future? As I was mentioning, the loss of hope is directly associated with suicide. It's a suicide predictor. Therefore, asking about how they see their future, or asking them, have you ever felt that life was not worth living? Or do you wish you could just not wake up in the morning? Are you or have you ever been suicidal? Have you ever attempted suicide? Or do you want to die? Do you feel so bad that you might end your life? Is there any actual plan now? If so, what are these plans? How you are going to harm yourself? Therefore, it's good to ask them clearly on this issue. And also protective factors. If they didn't commit this issue or tried, you can ask them, what has stopped you from doing this? This will guide you on the intervention, how to plan. Studies show that 80% of the people who have committed suicide or attempted suicide will give warning signs. They give warning intent of the suicide. they'll post something, they'll call for someone, or almost 80%, huge number. Out of 100 people who have committed suicide, 80 of them, they have already informed that they are going to commit suicide. Therefore, we have to be very sensitive. We have to be very aware of this issue. This is, is a shout for help. When someone is posting on social media, therefore it's good to approach in this way. And you have to ask about the family history of suicide and their pessimist and alcohol use. Not only alcohol use, all the drugs, especially the IV drugs, these opioids, they are highly associated with suicide. Therefore, you have to consider them as very high-risk people. When people have this suicidal thought and using alcohol or drugs, that will increase the risk. Then we are going to see the violence that is one of the dominant issues in the emergency psychiatry. People will be violent due to the psychiatric problem or due to the medical problem. When you try to understand the violence, the first thing is try to understand the reason why they are violent. Most of these, the violent behaviors, they are responses for a given stimulus. What has provoked them? Is it a family member? Is it a system? Is it the psychotic experience? Is it an auditory hallucination? What is the reason? What has, just narrating the story. Try to understand the story behind that. Then try to assess the immediate past and also the recent past and the more distant history of the violence. These are the best predictors for the future violence. Therefore, is this patient has a history of violence previously, a year back or 10 years back, whatever? Or they have tried to harm people before they visit you. Therefore, this is a predictor of the violence. If they have tried to assault the family member, or if they have broken the car, or they have acted out on the materials, then you have to be very cautious on this issue. This will predict the violence at the clinic. Is there any substance use? Alcohol, it will increase the risk of violence by 30% from the general population. If someone is alcohol user and having this violence behavior, it will increase the risk very much. Therefore, it's good to assess this issue. And the presence of personality, specifically clustering personality, which dominantly antisocial personality disorder. If someone has antisocial personality disorder comorbid with substance abuse, then the risk of the violence will increase with 100% from the general population. High risk. If someone is antisocial using alcohol, then the violence risk is very high. Therefore, you have to be very cautious, and having the mental illness will increase also the risk of violence from the general population. These are the differential diagnosis for the violent behavior. Psychoactive substances. If someone is intoxicated with drugs, stimulants, or alcohol, non-social personality, catatonia, medical problems, impulse control issues, sexual disorders, delusion, or seizures, dominantly temporal lobe epilepsy, bipolar disorder, interpersonal conflicts, this will lead to violence. When you assess the violence, the first thing is there are the behavioral predictors of violence, which are when, before they assault you, you can see that in the OPD, or they try to be violent on others, they will say a word, angry words. When they are talking, when someone is very angry, then this is a predictor of violence. You have to be very cautious when you are talking with them. loud language. If someone is saying something with very loud voice, then you have to suspect the violence. If they use abusive language, if they insult you, or if they are, saying something against the system or the hospital, abusive words. When they are using this, you have to be very cautious on this issue. Physical agitation, when people are making fists, pacing, they are restless, moving here and there, holding something, then you have to suspect this. These are the behavioral predictors of violence. Most of us miss this issue, but you have to be very cautious when people are angry, using these angry words, abusive words when they are loud. You have to sense this issue. Signs of the impending violence, if there is a recent act of violence, if they have acted out on that, as I was mentioning, if there is a verbal or physical threats, when people say, I'm going to punch you, you shouldn't, see it as the minor gesture. This could be a impending violence. You have to see it like that. If they are carrying weapons or objects with them, their phones or any material at their hands, if there are psychomotor agitations, if they are being agitated more and more progressively, you have to be very cautious on this issue. If they are alcohol intoxicated or in the withdrawal state, if they are very paranoid, if they have commanding hallucination, if there is organic disorder, delirium, if there is mania, this will predict the impending violent signs. These are just what I was saying, the issues. Best predictors, as I was mentioning, are excessive alcohol intake, history of violent act before, arrest or criminal engagement, which is more of associated with psychopathy or social personality, and history of childhood abuse. If someone has a combination of this, then you have to predict, or these are best predictors of violent behavior. The last topic we are going to see is rape and sexual abuse. Victims of this rape, they will visit our emergency at the gynae side or at the psychiatry side. They have this huge sense of shame, humiliation, anxiety. They might be very confused. They might be very outraged. Therefore, it's good to understand them. You have to be very reassuring. You have to be very supportive if someone is a victim of a given violence. You have to be non-judgmental, very empathic, and if it's possible, if the female is the victim of that assault, dominantly, females are the victims of the assault in our setting. Therefore, it's better if there is a female physician at the private place validating their emotions and also validating their avoidance. People might avoid you after they have experienced this traumatic experience. Whenever someone experiences trauma, the first reaction is, it's a break in safety. Then this world is no more going to be a safe place for them. Therefore, they might not trust you. Therefore, you have to validate that when they avoid or when they are very scared of you or when they are not interested to talk about this issue. You have to validate them. You have to give space to them. And also, it's good to work with the medical side, and you have to inform them there is a medical care. People might experience tear after sexual abuse, bleeding, and also legal consultancies. You have to inform them this is the options. And sometimes you have to properly record what you are doing on this issue because this is, legal evidence to people. Most of us don't document this issue. Documentation is, very poor in this country. You have to document everything, what you have discussed with the patient, what you have talked and what you have observed. When we see the treatment options, this is our last part. Both the psychotherapy and the biological interventions are there for the psychiatric emergencies. The first thing is you have to be very empathic. Someone with the healthy self-esteem at that state is not going to be at the psychiatric emergency. Therefore, if someone is at the emergency chain, agitated, then there is a clear damage on the self-esteem. Therefore, you have to empathize with them. You have to tell them, you understand them, how much it's painful for them. That's very good to you. Then try to understand how they have ended up at these states. The reason could be a biological reason. This could be due to the situations. This could be a developmental issue, or this could be the meaning of life, lack of meaning, existential forces leading them to at this psychiatric disturbance. Therefore, understanding the biopsychosocial state of the patient. Then multidisciplinary team involving psychologists, social workers, the security people. And when you approach psychologically, there is no a single approach for the patients. CBT or IPT, any form of psychological intervention, it's very helpful if you approach dynamically or if you focus on here and now. Almost you can use based on your expertise, but there is no a single form of psychotherapy that's effective to all patients. You have to individualize on the materials that I was mentioning, biopsychosocial issues that are precipitated, focusing on that. Then the most effective thing is psychoeducating people, educating the patients, the family, how this thing is happening, why they are developing this, how you are going to intervene this, the risk of that. And in some situations, as most of you, I hope, have experienced that, sometimes you might have no words to say, or you don't know what to say in that situation. You face this always, even in our interpersonal circle or in any situation. If there is, difficult condition happening, especially these behavioral disturbances or traumatic experiences, then you have to listen. Don't say anything. Saying a word is a problem, actually, in the emergency. If you don't know what to say, just listen. Calming yourself, focusing on your emotions. Therefore, the things that you say or do is a targeted thing. That's called intervention. But if you say a word or something from your own anxiety, if you act out or you respond to your own internal disturbance, then that is, a provocative issue. You'll provoke the patient. That's not helpful. Therefore, try to listen. Then you'll apply to biopsychosocial model or spiritual model in our setting their concerns issues. This is how we approach the emergency. In our setting, dominantly people tend to inject patients diazepam or haloperidol, and sometimes I try to think the psychiatry emergency or medical emergencies without haloperidol. If we have no any haloperidol or diazepam, what do we do? There are helping models. This is very effective evidence-based model, which is called verbal de-escalation. You can de-escalate people with your words. Your words are, you can use them as medicine. You can heal them with your words. Therefore, using a calm voice when you are talking with agitated patients, using calm voice. Sit down and ask the patient to sit down, then keep the distance. Try to establish a rapport, try to talk non-medical issues. How are you? Or you can comment on the environment, for example, if it's raining, now it's raining, oh, this rain. Or you can say if it's hot weather, you can comment on that. Therefore, connecting with the patient on that environmental issues. Try to build a rapport. Then listen to the concern of the patient. Patients, they could be agitated, they could be psychotic, but they have their own concerns. Therefore, you have to listen to them, what they need, what they want. Then you have to respect the personal space. We have these huge boundary issues. In the emergencies, people will try to touch agitated people, they try to hug them, or they will try to pray with touching them. This is a very problematic thing. Please try to keep the personal space. That is not only for your own safety, but for the patients. Give them space, Then don't be provocative. The words you say or your gesture, most of the communication is through our way of interacting, how we say something. It's not what we say. It's all about how we say. Therefore, focus on that, how you say, how you interact with that patient. Establish the verbal contact I was mentioning. Say a word. Try to interact with that thing. Then be concise on what you say. Just use minimal words, 1, 2, or 3 words. Then identify their feeling, their states. Sometimes you might agree with the patient, or you can agree to disagree. When they are commenting in given thing, you can agree to disagree on that issue. And it's good to clearly lay down a law or rule, clear limitations. When you are talking with them, you have to tell them they have no right to violate the right of other people. They have no right to assault people. Therefore, clearly tell them this, inform them. Whatever they are, at the psychotic state or agitated state, people will understand. Therefore, you have to tell them, and you have to set a clear limit on the interaction. And whenever you do something, give them a choice. For example, I do always ask the patients when I try to de-escalate them, if it's difficult to de-escalate with words, I will ask them, what do you choose? I'm going to give you pure medication. Do you swallow? Do you take this pure pill or injectable? Then people will prefer this. Oh, thank you for giving a chance. I will take the pure. Then empowering the patient and also connecting them with that patient. Therefore, giving an option to them. Always respect the patient, show the empathy in all stages. In every word that you say, you have to be very sure that the way you are saying or interacting is respectful and empathic. If it's not respectful and if you are not empathic, don't say anything. Not respectful thing and not empathic reaction will provoke the patient. That's actually precipitating issue, or it will provoke the issue. If the verbal de-escalation is ineffective, most of the patients will be de-escalated verbally, but there are small number of patients that needs other options. If the patient is not responding for your verbal de-escalation, you have two options. One is you will use chemical restraints, which is called medication, injectable medications. Another is a physical restraint. The physical restraints is you can use the sharp, soft issues, clauses, or you can prepare material for that with 5 people to start with extremities, with hands or with their legs. And you have to tell them actually what you are going to do. And the patient should be at the safe bed or at the stretcher. You have to do the safe way because sometimes, you might sustain trauma or you might lead to, there are cases in our setting, people sustain trauma, fracture on the ribs or suffocation, respiratory distress due to our physical restraints, how we implement it. It should be always in the safe way. And it's good to apply it in the 2 pointers, one arm and one leg, if it's possible. Sometimes people will use another extremity to feed or to show their interaction. But usually people chain at their hands or both at the hands and legs at the emergency. That's very problematic. They will not work or they couldn't feed. That's not safe. You shouldn't do this. And restraints, when they are applied, it should be at the safe room. And you have to revise that almost on the daily basis, every 24 hours, or you can see in between after 6 hours or after 12 hours. If the patient is calm, then you can remove the physical restraints and you can start the verbal de-escalation. You can start to connect with the patients. Pharmacological restraints or chemical restraints means when people are violent or assaultive, if they have this massive anxiety or panic state, that's difficult to control with the verbal de-escalation, or if they have these extreme side effect reactions or even the minor reactions, and also if they have laryngospasm, in that case, they might need intubation to that level. That's actually a very rare condition. I have never seen a patient that was in need of intubation in my experience in the residency or when I was working as a sealer. These are the options. The first one is benzodiazepines. Benzodiazepine short-acting, they are preferable. Lorazepam, PO is available in our setting. Therefore, you can use the lorazepam. If it's not available, diazepam is available everywhere. You can use PO diazepam. It will start to act after 30 minutes of PO injection. Therefore, it's good to try PO. The IV injection should be the last resort if the patient is not responding. You shouldn't rush to inject IV diazepam because there are many complications. And you have to rule out whether the patient is using alcohol. If someone is intoxicated with alcohol, adding diazepam or adding the benzos or the benzodiazepine family, they are acting at the GABA receptor, the patient will have severe complication, sedation, respiratory center sedation. They could have days of severe complication forming. Sometimes people might develop paradoxical reaction after you have given diazepam. 5% of them, the agitation might get worse in the process. You have to be very cautious on this issue. The last resort is antipsychotic medications. They are very effective on controlling agitation. Still, it's good to prefer PO if the patient is willing to use. Then, if they are not going to use that, try to use IM. Don't give IV haloperidol. In the vial, it says IV or IM, the preparation which is available in our setting. If you have no a direct cardiac monitor, you shouldn't give IV haloperidol. Haloperidol should be given IM or PO. Therefore, you can start with 5 milligram, depending on the state of the patient. You can give them every hour, depending on the state. Most of the patients will respond after the second or third dose. They will be sedated. They don't need additional dose after that. And most of them will respond with the first injection even. You can also use pure risperidone or olanzapine, haloperidol, and never give them depot medications. People sometimes, give them depot long-acting. Their time of onset is after 10 days. For example, Modicates or haloperidol Yetenaweg. You shouldn't inject them to control psychiatric emergencies. They will not help the patient. And you have to be very cautious on the side effects when you try to manage the patient with antipsychotic medications, especially young males or older females. They might develop severe reactions, extrapyramidal side effects. You have to prepare for that. Whenever you give the antipsychotic medications, at least you have to have trihexyphenidyl or R10, and you have to have diphenylhydramine. These medications should be available before you inject antipsychotic medications. You have to make sure. And also, if they develop dystonia, oxygen should be there. As we have mentioned, you have to transfer them to the ICU, depending on the state of the patients. When we summarize our presentation, safety is always the first concern on the emergency setting, the safety of the patient and also the safety of the staff or the physician, all the team, the guards and also others. You have to maintain both the physical and also pharmacological support options depending on the state of the patient. Most of the patients can be managed easily with verbal escalation, but some of them might need these physical restraints or pharmacochemical restraints. You have to use them. Be careful when you are assessing the agitated patient or disturbed patient about suicide. Try to screen for addiction, especially alcohol, IV drugs. Currently, we see people use stimulants, cocaine, cannabis. It's very prevalent in young adults or high school students, tramadol, opioid abuse. You can see, try to screen for substance when you encounter with behavioral disturbances. We are mentioning these issues. And when you try to evaluate the patient, please look for the potential weapons people might use to harm you or to harm others. IV stands or other metallic materials, scissors, anything which is potentially used as a weapon. Therefore, you have to be very cautious on the environment. People might use these materials to harm others or to harm themselves, and give yourself and the patient equal access. This is what I have. These are my references. And thank you for your attention, and let us try to see the questions.
Thank you very much, Dr. Eshetu. So that was a very you've given us a very comprehensive overview of the most common psychiatric emergencies. So you walked us through the essential steps for assessment, stabilization, and appropriate management. So thank you very much for that. So having said that, we can directly proceed to the Q&A. So I will share my screen and we'll go over the questions together. So
Okay, I'm seeing them. The first one
okay.
says, but
How do
how
you
do
know
we know them before we meet if we are
evaluate?
evaluating them for the first time?
So this
Oh,
question was addressed while you were speaking about aggressive patients.
therefore, it is how we talk with people. When people try to visit or they come to us, there are different ways. They will be brought by the family, most likely, or with the police, or they will be referred from other setting. Therefore, you have to pick this data. For example, referral paper. In the referral paper, it might say schizophrenia was on medication for the last 10 years. Therefore, before you evaluate or engage with talking on this issue, you have to see that. Or when people are referring the patient, you have to get the issue on the referral, the information about that patient. That's what I was trying to say. The second one is what psychotropic medications are contraindicated for daily rest patient? Very nice question. Actually, we can have another webinar on the delirium because it's very challenging for many people when we see at the medical side. And the delirium, the first one is you have to remove these benzodiazepines. Don't use diazepam. The benzo family for the daily rest patient, except it is an alcohol withdrawal patient, or it is withdrawal secondary to benzodiazepine use. Benzodiazepine withdrawal or alcohol withdrawal. Therefore, we shouldn't use IV diazepam. People use that, but the paradoxical reaction, the patient will be at the difficult state, and it's very difficult to manage them with these benzodiazepines. And if there are sleep issues, we can use the short-acting lorazepam in rare conditions. But the first line in our setting to use for the delirium is haloperidol. Haloperidol PO or haloperidol IM. You can start its PO with 5 milligram or 2.5 milligram, also injectable with 0.5 or 5 milligram IM. You can give them after 1 to 2 hours to the maximum dose of 15 milligram to 20 milligram, depending on the kg and the state of the patient. Therefore, try to use haloperidol. And it's good to avoid other low potency antipsychotic medications, even olanzapine and also CPZ, they are not recommended. And also benzos shouldn't, if it's not alcohol related delirium. Okay, another question says, how do explain what we call evil eye and possession with spirit in psychiatry? And there is a general misconception that those patients with above cases will die if they are given medications and health care, though I don't know what the medications are. And unfortunately, I have seen two of the patients in my village who died after they had been given medication. Please, how do we convince them? Oh, this is very practical question. We see this on the multiple encounters. You know, this is a common sense. The evil spirits, one is they say they will die. Another is, you know, if once people are exposed for the injectable medication, the evil spirits will never leave them. They are going to suffer for the lifelong due to this issue. These are actually the common misconceptions. In my experience, I have never seen a psychiatric patient who has died due to the injectable medication. This is the clear misconception. Therefore, we have to educate them. That's why I was saying biopsychosocial spiritual model. You have to understand their sense when they say this. Then the most common model I try to use with them is, spirit is not a visible thing, and the spirit is not going to have an interaction with this drug. We are not going to access it, which is actually the theological teaching in the Muslim or in the Christian theology. They understand these spiritual beings, they are experienced at the spirit of the person. Therefore, when we inject the medication, it is the biological thing. It's like a food, or it's like a water they drink, or it's like a milk. Therefore, trying to explain this, the biological issue has no association with the spiritual part, but sometimes people will have a difficulty to understand these issues, and it's good to focus on that. And the cases that you have brought to this discussion, in Ethiopia, it's very challenging to attribute the days. Most of the cause of the days are not known, even in the hospital setting, It is a possible cause of death that we put. For example, even the patient could die due to the renal issue, but the immediate cause could be a stroke or, coronary syndrome or whatever. Due to this lack of sophisticated investigations on the health system, it's very difficult to attribute the cause of death for the injectable medication. There are many factors. For example, hypoglycemia could be the reason, or other issues. Okay, the second question.
I can read the questions, Doctor.
Okay, thank you.
Okay. So the fifth question reads, so most of the psychiatric patients I've come across are restrained, handcuffed, or legs tied, etc. So doesn't it contradict with what you taught us? So breaching their personal space and making them more aggressive.
Yes, actually we see the patients which are chained, and due to this they apply metallic restraints. They experience fracture, contracture. When I was at Wolkite, I was seeing a patient who was chained for 10 years and he has contracture at both of his hands. He can't use or he can't flex his hands. That's very problematic. Infection at the chain sides. That's very problematic thing, and we have to teach people how to do this. The first thing is, in the hospital setting, if you apply a restraint, it should only stay for a day, or after 12 hours, you have to reevaluate the patient. And the basic thing is a chemical restraint, a medication. We use medications. Therefore, we rarely apply restraints in psychiatric settings. Commonly, people apply restraints at the community, actually. It's at the home they use, which is their own way of dealing. But in the psychiatric hospitals, it's not recommended to restrain patient. It is, the last option which is implemented after psychiatrist has ordered to apply restraint. The guidelines are like this.
So thank you. So the sixth question reads, regarding sexual assault victims, should contacting police be taken into consideration, or do we give the choice to the victims, since the evidence might not be as apparent after a while, even if they decide to report it later?
There are many medical legal issues on this reporting system. In the West, you have to report for the legal system. The legal system enforces you. You have to report this. Not only the sexual assault, if there is a physical abuse on the minorities, on the kids or the females, you have to report this to the legal system. In our setting, there is no clear legal system to do this, you know. But you can do that for there is an affair, Eshetu, and it's another good day office. Therefore, you can report to that. But basically, what we proceed is with the patients. We'll tell them, we'll offer the option. There is an option, there is this service, there are the phone accesses. We'll give them this option for the patient. Sometimes, after the sexual assault in our community, it's very challenging for that woman to, to interact with, even to accuse this. If once it is legally known or people know this issue, she has the risk, to marry. Socially, it's not acceptable. Stigma issue. We have to work on this issue. It's the responsibility of the mental health professionals and also the responsibility of all the physicians and other people. There is a huge burden on them. Our role is, empowering them, educating them to defend for themselves. You can't solve the problem of people. People are here to solve their own problem. Even in the therapy sessions, your role is to enable them, to empower them. Then they will start to be the voice for themselves.
Okay, thank you. So the seventh question reads, is brain imaging mandatory for all psychiatric emergency patients?
Okay, brain imaging, actually, it's all about the resource, If anyone has a behavioral disturbance, brain imaging is indicated. But we have this resource limited setting. For example, in St. Paul, you might have only 2 machines, serving these people, more than 5 million on the black line. And the private setting, it's very costly. That's all about these social factors and the resource issue. If it is an ideal, if people could afford this, brain imaging is very mandatory thing. It's all about the resource. If you are working at the resource limited area, most of our patients are poor, they're coming from rural area. If you cost them some of their money for the imaging, then they will lack, or there would be a difficulty to buy the medication, to pay for the beds. Therefore, it's all about the resource. Unless and otherwise, it is indicated. Any behavioral disturbance, for the first time, it needs imaging. Even functional imaging, scanning the neuronal level assessment. That's very important.
Thank you. So the eighth question reads, is there any data related to psychiatric emergencies in healthcare professionals, especially in Ethiopia? And how do we reduce the risk?
That means assault on the health professional.
I
Right?
guess I'm not really sure. I think that's what they mean to ask.
Let me read which questions.
It says, is there any data related to psychiatric emergencies in the healthcare professionals, especially in Ethiopia? And how to reduce the risk?
Okay. Therefore, they are victim of the violence, I think. The question says. When we try to see, I don't know the national study, almost all the studies are institutional based cross-sectional studies you do in the given institution. There is no national data to this issue that I know. The issue is when we assume that these psychiatric patients, dominantly psychotic patients and bipolar patients, they are very violent. The data is the reverse. They are the victims, actually. In real scenario, they are more victims than abusers. But health professionals would sustain this. in rare condition, if you don't implement these measures that we are mentioning, if you don't keep your personal space, if you don't remove the weapons, it will sustain that trauma. I have seen cases of residents who are reporting that the patient has slapped them or they have thrown a table on them or like that. Therefore, that happens, but we have to focus on the safety. That's the measures will decrease that definitely.
Yeah, thank you. The next, are there any specific training programs available for healthcare workers respond to mental health crisis?
Actually, we can do that. We can implement on that in the MH gap, for example. It is designed for the non-psychiatric health professionals, which is a guideline, mental health gap training, in which there are principles how to approach these issues, how to manage psychosis, how to manage other disorders. Therefore, MHGAP is internationally designed by WHO. We can use that. But crisis management therapies, you can get that based on the need or in their undergraduate or postgraduate courses. They should learn this properly. For example, internal medicine residents are touching to psychiatry, or other nurses or general practitioners when they are attaching psychiatry, they should learn properly during their attachment stay.
Okay, thank you. The 10th question reads, is there any laboratory tests useful for psychiatric emergency patient?
It depends on the state of the patient. As we were saying, 1/3 of the medical patients will present with behavioral disturbance. For example, stroke commonly present with change in personality or aggression or psychosis or delirium. Therefore, depending on the state of the patient, we need the investigation. There's common investigations. There's the random blood sugar level or CBC, renal function, liver function test, thyroid function test. These are the baseline tests that we have to do. But depending on the state of the patient, for example, if someone has very emaciated or wounds at different area, you tend to screen for HIV or chronic illnesses or cancer or whatever. Therefore, it depends on the individual patient. It should be very individualized, and always try to rule out medical things first before you declare this patient is psychotic. Psychosis should be ruled out. That's the criteria actually. In the schizophrenia or in the mood disorders, one of the criteria is to rule out the existence of biological causes, organic cause for that behavioral disturbance. You have to thoroughly investigate the patient, depending on the symptoms, depending on the age, and also the type of neurological findings. Yeah.
Okay, thank you. So the 11th question reads, how could we give psychotherapy for emergency psychiatric patients since most of them have no insight and their thoughts are distorted, unless in exceptional cases like suicide and psychiatric disorders due to another medical condition or due to substance use like withdrawal and intoxication. So in the patients will regain their insight in a short period of time. So would you give additional description on this area?
Okay, thank you. When I was mentioning about the psychotherapy, actually, psychiatric interview is by itself, it's a therapeutic process. Psychotherapy, it doesn't start after you make a diagnosis or, therapeutic intervention starts at the first encounter, with the first observation, with the first talk. That should be a therapeutic. that should be a healing process, the way you say. When I'm saying about this issue, it's not to say you have to start CBT for the psychotic patient, or you have to start IPT for the delirious patient. I'm not saying that. I'm saying how we communicate with the patient should be therapy. Therapy, for example, in the dynamic sense, in the psychodynamic sense, psychotherapy is the way how you interact. This agitation is the reaction, the state of the patient. Like, this is a transference. Then your counter transference, you have to sense that, and you have to be very attuned how to react to that. That is therapy, actually. General process is, a therapeutic process. When I'm mentioning this, I'm saying that issue. It's not to say start CBT or IPT like this. The whole process should be very therapeutic, especially in the supportive psychotherapy. Understanding the patient, empathizing with the patient. Even, in the most of the studies, almost 40% of the therapy outcome depends on the therapeutic process, therapeutic alliance. It's not due to your technique. It's not due to the type of the therapy that you use. Basically, it's all about the therapeutic alliance. The way you use that material. It's the way how you do. I was mentioning that. Thank you.
Thank you. So the 12th question reads, what is the importance of doing serum calcium as a baseline investigation? And is doing ionized calcium level mandatory along with the serum calcium?
No. It depends on the neurological finding of the patient. When I was mentioning the investigations, it's not all nothing. I'm not saying you have to do this all the investigation to every patient. That's not the way. It's depending on the state of the patient and the physical finding of the patient that suggest that disturbance.
Okay, thank you. So the 13th question reads, most of the attendees in psychiatric emergency refuse to let their relatives take IV medication because of cultural beliefs that the patient's condition is due to an evil spirit, and they fear the medication will kill the patient. So how should we address such attendees in the psychiatric emergency setting?
I think I have answered this in the previously. It's all about the knowledge gap, basically. The dominant issues which are reflected on the attitudes are due to the knowledge gap. People, once you know the truth, it will set you free. Therefore, it's focusing on the truth, discussing with the patient, approaching the collaterals properly, using the respectful way, showing the empathy for them, talking with them on the level that they understand you, and the non-judgmental approach, In our setting, the more you are educated, people tend to, minimize the request of other people, or, you tend to comment on them, or that's very problematic thing. The way you treat them. It should be very respectful way. Where you respect people, they will understand what you say. They will listen to what you are saying. But if you don't respect them, even that wrong belief, you have to initiate with that. Okay, why do you think this is the way you are thinking like this? How should we engage with this? We have to respect their religious belief. We can engage with them, with the religious leaders, You can, integrate both. They can visit the churches or mosques or traditional healers. And, you can do this in combination. When you disregard their belief, they will avoid the health system. These people are like these physicians, they have no respect for the traditional belief or customs, whatever. Therefore, it's all about the respect and empathy to the collaterals also.
Okay, thank you. So the 14th question reads, is suicidal ideation the only difference between a major depression as opposed to a major depressive episode?
I didn't say that in the presentation, and I didn't discuss about the major depressive disorder or major depressive episode. Suicide could happen in any disorder, but almost 95% of the suicides, they are associated with mental illness, whether it's depression, whether it's an addiction problem, whether it's a mood bipolar disorder, or whether it is an anxiety, or whether it's a personality disorder. So it's associated with mental illness mainly. Suicide is due to the mental illness. That's the message. And depression is the commonest cause. Almost 60% of these patients, have depression. Therefore, depression is the commonest cause for the suicide, but other psychosis and addiction, especially alcohol and IV drug users, is highly associated with suicide, borderline personality disorder, and the like.
Thank you. So the 15th question reads, how do we manage dystonia in acute psychiatric emergency setting and its causes?
Dystonia, basically, it is a side effect of antipsychotic medication, dominantly the high potency first generation, which is seen on the young adult male patients, but it could also happen in any patient. Therefore, the first response is, the problem in dystonia is it might kill a patient if the dystonia is happening on the respiratory muscles, if it's involving the laryngeal muscles or the chest muscles. Therefore, people could have a difficulty to breathe. Therefore, in that state, you have to implement muscle relaxants. Basically, you can use the diazepam, 10 milligram IV start, and also depending on the oxygen status, you have to support the patient with oxygen. And sometimes if it's very severe enough to the level of hypoxia, you have to intubate the patient and also to intervene. But most of them will respond with this diazepam, and also you can use diphenylhydramine also.
Thank you. The 16th question reads, what is the strategy for a patient having both a psychiatric emergency and a chronic disease? And how do we manage?
These patients with mental illness, they are not, protected from biological or other common medical disorders. This could happen. This is a common thing that we see. Therefore, we have to approach the patient in the integrated way. That means psychiatrist and internist, or the nephrologist in this case, should be involved. Therefore, the patient should stay on the safe place for that patient. Let us assume that if the patient needs dialysis, they should stay at the renal side, and psychiatrists should visit them on the daily basis or on the weekly, depending on this. If the patient has a stable renal issue, and if they have these psychiatric disturbances, you can treat them at the psychiatry side. But this is a multidisciplinary issue. Currently, generally, the medicine is like this, Some patients could have a surgery at the surgical side, but they could develop myocardial infarction. Therefore, it is all about the patient. It is not about the name of the disease. Therefore, where is the safe
Thank
place for these patients? Yeah, thank you.
Thank you. So the 17th question reads, what's your take on an alcohol intoxicated patient fluid and its paradoxical effect in causing?
Oh, very good. When the patients are intoxicated, the first thing is please avoid benzodiazepines. That's the first thing. Avoid diazepam. Once the patient is intoxicated with alcohol.
Thank
Then,
you.
if it is very difficult to control this, then you can use antipsychotic medications. That means haloperidol injectable or haloperidol PO to help the patient to control the agitation. But when the patient, this encephalopathy, Wernicke's or Korsakoff's syndrome it's all about the withdrawal problem. It's not the intoxication. It is due to alcohol withdrawal. When you approach the alcohol withdrawal patient, they should be immediately referred to the psychiatry side, or you have to involve the psychiatry side. Psychiatrists should see them and start the standardized treatment depending on the severity of the withdrawal. Sometimes patients present delirium 3 months, sometimes with mild withdrawal, sometimes or with moderate or severe withdrawal. Depending on that, the management is based on that issue. Therefore, you have to involve the psychiatrists, you have to consult immediately. Then the protocol, you will proceed with that. When you give them, for example, 40% or like that, you have to supplement the vitamin. These are there are different guidelines based on that. Always involve the psychiatry side. Don't manage withdrawal at your own time. That's the problem, actually. I see patients at the emergency, they have stayed and they will develop encephalopathy due to mismanagement. If one suspect and you have adequate history, please try to involve psychiatry as early as.
Thank you. So this will be the last question that we're going to address since time is a constraint. So the 18th question reads, what is the rationale behind not giving haloperidol intravenously?
I was mentioning it. It is due to the cardiac side effects, QT prolongation. If you give haloperidol IV without cardiac monitoring, it will have these effects, QT prolongation, and people might die due to that. That is the reason, cardiac side effect of haloperidol.
Okay, so thank you very much. So this will be all we're going to be addressing for the Q&A. So having said that, we'll directly proceed to the post-CME quiz. Okay, so the first question reads, one of the following is a sign that helps us to predict violence. So the first choice is verbal or physical threats. The second choice is progressive psychomotor agitation. The third choice is excitement. The fourth choice is increased respiratory rate or restlessness. And the fifth is all. So if you have joined us at menti.com, please try to input which choice you've selected. Okay, so we have one response. It says all.
It's all.
Okay, so all is the correct answer. So the second question reads, which of the following is true about verbal de-escalation in psychiatric emergencies? The first is maintain a physical distance of 2 feet. The second is agree with all the things that the patient claims. So the third says lays down the law or set clear limits. The fourth is establish a physical contact. And the fifth is none of the above. So I believe most of you have responded lay down the law or set clear limits. There is another that says none of the above.
The answer is this, to lay down the laws or set clear limits.
Thank you, Doctor. Okay, the third question says, increased rates of suicide attempts occur in patients with, so the first choice is panic disorder, the second is social phobia, personality disorder. So the initially fourth choice was substance use disorder, and the fifth is all of the above. So some of you have answered substance use disorder. Okay, so there's another response that says all of the above.
You know, the question is not about the most common problem. It is all about the risk of suicide, and suicide is very common on the addiction problem. It is very common in panic disorder, social phobia, and personality disorder also. Therefore, all is the answer.
Okay, thank you. So the presence of medical illness should be strongly considered when. So the first is when psychiatric symptoms appear suddenly in a previously well-functioning person. The second is presence of neurological symptoms. The third is psychotic symptoms that appear for the first time after the age of 40. The fifth is increased temperature, pulse or respiratory rate, and all of the above. Okay, so some of you have answered all of the above. Others have answered the psychotic symptoms appear for the first time after the age of.
As mentioning, almost all of them are mentioned on the slide.
Okay, thank you. So this is the end of the presentation. So we've attempted the quizzes all together. So once again, I would like to thank Dr. Eshetu on behalf of Yetenaweg and our organizing committee, the Ethiopian Medical Association. I would like to thank you for your valuable contribution to this webinar. So your expertise has left us better prepared to recognize and effectively respond to psychiatric emergencies in our communities and in our practice as well. So once again, thank you. I would also like to thank our attendees that have joined us. I would also like to thank my co-hosts, Dr. Abenezer and Dr. Ruth. So thank you and good night.
Thank you. Have a good time, and for the time also, have a good time.
Thank you, Dr.